Okay.
Good evening, dear colleagues, young intensivists, and students and doctors from other disciplines. So today is Critical Care Sunday webinar number 124. And the topic for today is ICU-acquired fever. We will be covering mainly non-infectious causes of ICU-acquired fever, as we have already covered nosocomial infections in detail. However, Dr. Panja will touch briefly on nosocomial infections also. So Dr. Panja, Soren Panja is the speaker for today. Sir is the head of critical care and internal medicine at NHRN Hospital, Kolkatta. He's also the administrative lead for NH hospitals of West Bengal, and he's the chairman of ICSM branch West Bengal. So I will hand it over to you, Dr. Panja, sir.
Yeah. Good evening, Dr. Bansal, for kind introduction and giving me this opportunity to talk on this prestigious platform. And I know there are so many viewers, and as you have seen, so many of my students, they also view from your channel. They get enriched by all these webinars. So without any wasting my time, I am just I am about to start my session. Share my screen. Just a moment.
We can see a blank screen. Can you go to the next slide?
Yeah, just a moment. No, not actually. I have not been able to share till now. This is my share desktop. Okay, can you see?
Yes, we can see.
Okay. Okay, so today I will cover the fever in ICU, and as we know, already there are already whatever we have discussed with Dr. Bansal earlier, there are nosocomial acquired fever in ICU has already been discussed and in previous discussions. So I will try to restrict myself more of non-infectious side in the ICU fever than infectious fever. So fever in ICU, if you see, this frequency of the ICU has been variably quoted between 25 to almost 50%. And the presence of fever often prompts our change to patient management. And not only that, the acquisition of fever in ICU patient is associated with different kind of the adverse outcome in medical ICU patient. And fever, as we know, that this is basically there are fever mechanism, and the common mechanism is there is hypothalamic set point, which is mainly maintains our thermoregulatory center, and that can be reset to a defined temperature level. It may happen because of the cytokine production, or sometimes it may also give rise to shivering or non-shivering that can also cause heat production inside our body and heat conservation in the peripheries. So that is the basic mechanism. So either hypothalamic set point change or production of the heat in the body, that is the most important. And this is a normal temperature usually varies between 37.5 to 38 degree in normal. And if we are exercising in a physiological state, the temperature may increase by 2 to 3 degrees centigrade. So usual by definition, the core body temperature, if it is more than 101 degree Fahrenheit, then we call it as fever. And lower threshold may be most important is in our ICU patient. Sometimes patient is immune compromised on defined kind of your renal replacement therapy or on any chemotherapeutic agent, neutropenic patient. So any immune compromised host, this definition does not apply. And not only that, even without, sometimes the temperature may not go beyond your 90, sometimes your 38 degree, or sometimes 37.5 degree. So that's why it is usually for a normal immune competent patient. And hyperthermia, if the temperature rise more than 40 degree, or sometimes we call it more than 105 degrees centigrade Fahrenheit, then we call them as hyperpyrexia. So the fever and hyperpyrexia are a little bit defined entity in terms of the diagnosis as well as management. So our approach sometimes differ on that basis. And hypothermia, if the temperature is less than 35 degree. And there are certain benefits of the fever. So I am not going in details. So fever usually gives our body some kind of protection by defined molecular mechanism, as well as sometimes the cells which is destined for the immunity, they become more and more competent, and there are also different kind of the cytokines, so that can give rise to a change in our body. And ultimately the benefit, the host becomes that get rid of different kind of the microorganism, particularly plasmodium species, spirochetes, bacteria. And also not only that, the benefits are enhance the parameters of the immune function, improves antibody production, activates T cell, produces different kind of the cytokines, and enhance neutrophil and macrophage. And these cytokines also inhibit the propagation or sometimes the population of the bacteria or different kind of microorganism inside the body. So as I was discussing that fever and hyperthermia, these are two different entities. So usually fever means when we are dealing with a case of temperature within 101, between 101 to 102 to 3 degrees centigrade. But if the temperature goes beyond 104 to 105 degree, then we call something that hyperthermia. So there are different kind of mechanism, as well as not only that, if we compare the fever and hyperthermia, the approach in the diagnosis as well as management differs. That is very important. So usually the fever, when we talk about the usual fever, so there is a change in the thalamic set point. So that's why if we give sometimes paracetamol or any antipyretic agents, that patient may respond. But in case of hyperthermia, the mechanism is little different, that hypothalamus, the set point may not change. And it is the mode of a production of the defined kind of heat that give rise to the non-responding, non-responder, the defined kind of antipyretic agent, particularly paracetamol. So that is very important. And if we discuss about what are the usual causes of fever, I will discuss different type of the case scenario. Before that, just consider an environment of the ICU. The ICU environment, there are different type of the specialized mattress, hot light, air conditioning. Sometimes patient is going for the different kind of treatment, cardiopulmonary bypass, peritoneal lavage, dialysis, continuous hemofiltration. So because of this environment as well as change in the milieu of the patient, in their management also, that can also give rise to the fever. That is the usual causes of the fever. And there are sometimes the hyperthermic syndrome, or what I was discussing, that is another cause. And there are different, the hyperthermic means if the patient is usually more than 105 degree temperature, that usually happens in this particular condition. And usual causes of this fever in ICU patient, so infection is almost 50%, that is the cause of the fever. So infection, if we discuss about the different kind of infection, so it may be a pneumonia, different type of the line, and the device related infection, sometimes the Clostridium difficile infection because of the use of the antibiotics that may, or sometimes even community acquired Clostridium difficile infection is also important. And sometimes the patient might have a defined kind of scenario, like particularly in the cirrhosis of liver or chronic liver disease, the spontaneous bacterial peritonitis. These are common symptoms, common causes of the infectious cause of the fever. There are less common, like acalculous cholecystitis, cellulitis, catheter-associated urinary tract infection, or sometimes the ventriculitis because of the external ventricular drain, or very rarely sometimes the endocarditis or any device in the heart may also give rise to the infection, and that can cause fever. And almost 50% are non-infectious. That is very important. And when we will discuss about the non-infectious cause, so just go like one systemic approach. So this systemic approach, like first you consider whether the procedure related or not, like hemodialysis, bronchoscopy, so blood transfusion related, or sometimes post-operative fever. So these are because of our your intervention or procedure related cause of fever. And sometimes if there is a medication use, that can directly give rise to the drug fever, and sometimes the medication induced hypothermia, particularly some syndrome like serotonergic syndrome, neuron malignant syndrome, or malignant hypothermia. These are the cause of the medication related. Not only that, sometimes the vehicle used in the medication is also may cause give rise to the fever. And sometimes the sterile pulmonary inflammation like fibroproliferative ARDS, organizing pneumonia, so that can also give rise to the fever from the pulmonary cause, and pulmonary embolism or any other thrombophlebitic condition may also give rise to the fever. There are other causes like pancreatitis, thyroid storm, rheumatologic disease, malignancy, or sometimes HLH or hemophagocytic lymphohistiocytes. These are also sometimes rare causes of fever. So then I will start with the case. This is I will discuss some of the cases for better understanding. So this is the case number 1, 32 years old gentleman admitted with a history of fever for 3 weeks, multiple joint pain, malaise, easy fatigability. And on examination, this patient had pallor, petechial rashes, cervical axillary lymphadenopathy, hepatosplenomegaly. So this is a case scenario. I will invite the house to discuss if there are basically. So if we look at this case, 32 years old gentleman, history of fever for 3 weeks with multiple joint pain, malaise, and easy fatigability. So with these symptoms, sometimes we think of some of the infection that usually causes sometimes the joint pain or but usually fever more than 2 to 3 weeks is not infectious. It is most commonly the non-infectious cause should be think. Usually infectious causes of fever other than some specific infection within it's usually subsides by 1 to 2 weeks. But there are certain specific cause of the fever like endocarditis, or sometimes some patient with any device related infection, okay, or any content abscess, or sometimes tubercular infection. So these are some of the specific infection. But in general, usually the fever within 1 to 2 weeks, most of the infectious causes, or in tropical country, they usually subside. But once the fever is more than 3 weeks with multiple joint pain and easy fatigability, then we should also think about other causes also. And this patient had pallor, petechial rashes, cervical and axillary lymphadenopathy, and hepatosplenomegaly. So lymphoreticular system has also got involved. The lab investigation when we received, in the lab investigation, you can see the platelet count was on slightly lower side and hemoglobin on the lower side. This patient had the creatine values of 1.5 milligram per deciliter, LFT, there is alteration of the LFT, but this patient had ferritin of 6,000, fibrinogen of 100 milligram per deciliter. Because of the joint pain, RA factor anti-CCP antibody was run, that was negative, and blood and urine culture sensitivity was pending on the initial days, and then the tropical markers, whatever we had received, was negative. Chest X-ray, ultrasonography, whole abdomen was non-contributory. So with this basic first day investigation, can we guess what is the diagnosis?
So anyone from the audience would like to type in the chat box? So we'll wait for 2 minutes, Dr. Panja.
Yeah, please.
So you can think along autoimmune lines if anybody wants to make a diagnosis, autoimmune lines, any diagnosis along autoimmune lines. So one thing you should note is ferritin is high. Ferritin is very high. So there is nothing from the audience. So Dr. Panja, I will make a guess.
So if we analyze these investigation results, so remarkably patient has got low hemoglobin, low platelet count. So that can happen with even a chronic inflammatory condition also, or it may be also sometimes pointed to a particular disease. Another one is creatine is also raised. As Dr. Bansal mentioned, collagen vascular disease or any kind of vasculitis you must think about. amongst the non-infectious causes. And other than some specific infection, okay, specific means a tubercular infection or sometimes some infection in the content space or endocarditis, they may also give rise to this kind of picture. And if we look at the LFT, the AST and ALT was raised, and the INR was also slightly raised, and look at the ferritin and fibrinogen. So ferritin is quite high. So this type indicates that there is inflammation going on, and whatever this we are discussing, collagen vascular disease, vasculitis, you must keep in the diagnosis. And sometimes other causes also you can think that we will just discuss. So because on the basis of this suspicion of infection, this patient was being put on IV antibiotics, antipyretics, and other supportive measures was taken. That was in the actually patient was disposition was in the wards. But on the day 4, this of the ITU stay, patient had a deterioration with hypotension requiring vasopressor support also. So that day patient actually over 2 to 3 days patient deteriorated. So antibiotics was changed and also antifungal added by the after discussion with the primary team. And this patient was also got intubated, ventilated because of the tachypnea and requirement of the high vasopressor support. So on the day, this was the day 4, and on the day 5, we followed the same patient condition was gradually deteriorating. So any guess, any diagnostic possibility? So if we are dealing with the IV and with antibiotics, antifungal, patient is not responding, rather patient is deteriorating, requiring vasopressor support as well as the defined kind of the ventilatory support. So we are being giving the defined kind of the organ support. It means probably this patient is not suffering from some kind of infection. So there may be beyond infection we should think. So by 4th, 5th day, we receive the investigation results also on a daily basis. Sometimes we repeat the investigations. So on that day, the hemoglobin was 6.5 gram. Total count reduced from the earlier one to 2,000. Platelet count was 22,000. Patient had sugar and creatine. You look at the creatine has raised. Look at the LFT. There is alteration of the LFT. So bilirubin raised, AST, ALT elevated, and ferritin gone up from 6,000 to 18,000, and fibrinogen remains low. And if we look at the triglyceride is high. LDH was 1,700. That day also we received other antibodies like anti-VCA antibody, anti-EBNA. Basically, these are screening for the sometimes the Epstein-Barr virus infection. We send it, and anti-scrub typhus, because the ricket cell fever is also sometimes present with 2 to 3 weeks of fever. So that's why it is important. So anti-scrub typhus antibody was negative, and blood urine culture received, it was negative. Repeat tropical markers like malaria, dengue, all are also negative. So from this, what next? What do you think? Any revision of the diagnosis on the basis of fever for 2 to 3 weeks? Then there is sometimes indicator that Epstein-Barr virus infection may have happened. And
Dr.
right now,
Panja, we'll wait for 2 minutes. So
yeah,
any comment from the audience? See, the ferritin is going up. The answer is very obvious. Look at the ferritin. And infectious mononucleosis is positive. He has a viral infection. So the ferritin is so high, there is only one diagnosis in the setting of a viral infection. And he's not responding to antibiotics, antifungals. So I think I'll put the answer as HLH secondary to infectious mononucleosis, Dr. Panja.
Yeah, Dr. Bansal, you are absolutely right, because this patient, later on we will see what is happening. So this is one of the important possibilities. And if this anti-VCA antibody, anti-EBNA antibody, these are not positive, then you can think other things like collagen vascular disease, or sometimes adult Still's disease also present with this kind of the ferritin level of very high. Sometimes the ferritin, so there are very few conditions where you may find that the ferritin is more than 10 to 15,000. So HLA is absolutely right. Sometimes adult Still's disease is another condition where you may get a very high ferritin level.
Dr. Panja, one thing I would like to add, that even in sepsis, the ferritin goes high. Not so much. 18,000 is very high. That is almost diagnostic for HLH. But the thing is, in sepsis and in HLH also, you get ferritin high. One has to distinguish sepsis from HLH. And sepsis and HLH is not the same thing. You don't get HLH because of sepsis. There are two distinct pathologies and the physiology is different. People often think that sepsis and sepsis can cause HLH. That is wrong actually. So sepsis and HLH, there are four distinguishing features. One, there will always be high fever in HLH, while there may not be high fever in sepsis. Sepsis may not have fever. Second, there is generally hyponatremia in HLH. There is no hyponatremia ever in sepsis. Third, splenomegaly is seen in 95% of the patients of HLH on ultrasound. And fourth, you may get a rash. You will this thing HLH, but in sepsis you don't get a rash. What you get is a rash secondary to DIC if you get anything. So these are the four distinguishing features between sepsis and HLH, because sometimes it is very difficult to distinguish between sepsis and HLH. As Dr. Panja will also agree, and if he wants to comment anything on that.
No, you are right. Only thing that just to modulate, sometimes sepsis, there may be rash, but that rash may be of defined kind, as you mentioned, DIC, or sometimes some sepsis patient might have thrombocytopenia is also one of the features, okay, because of the at certain point of the sepsis syndrome, there may be bone marrow suppression also. So yeah, but definitely I agree that the ferritin so high, usually infectious cause we should not think much, rather the ferritin may be high 6,000 8,000, but usually 18 20,000 ferritin, okay, this is very relatively less common in your usually more common in this type of the HLH or sometimes adult disease, okay. So these are more common, and already Dr. Bansal mentioned other pointer, okay, that can differentiate between sepsis syndrome and HLH. That is very important because treatment is totally different, and not only that, if you by mistake treat one septic patient as HLH, that is also will be very detrimental. And also, if you don't intervene once you diagnose as HLH, there is no point waiting for any further time, because the patient may deteriorate very fast. So that's why it is very important. So what about the investigation? So immediately we put this patient for the bone marrow aspiration, biopsy, and new set of cultures also is sent, because we are giving a patient treatment in a line of HLH. So we will give obviously some immune suppression also. So sometimes we repeat the cultures to rule out just infection. And injection dexamethasone was being started, and then we also thought about the antibiotics de-escalation. That time antifungal actually stopped, because first set of culture was not showing any antifungal element. Though initially on the fourth day we started, but we stopped it. And antibiotics de-escalation at this point actually we considered. So really we kept one broad spectrum antibiotics, but the gram positive or something, that patient was also being put on the teicoplanin, that we already stopped. So that details I have not given because of the time constraint. We want to also consider the approach. And other supportive care was continued, means the patient was on gradually vasopressor, ventilatory support, depending on the age. So the diagnostic possibilities, obviously we are discussing that the biopsy actually suggest, and after 2 to 3 days we received that aspiration as well as the biopsy report. So it was suggesting there is hemophagocytosis, the cytopenias was there, and but after putting the patient on dexamethasone, patient's improvement in the clinical condition started, and gradually after 3 to 4 days the patient was being off vasopressor support. Extubation was also done on the day 10, and patient was being discharged after another 5 to 6 days of the recovery. But patient, the treatment you should continue, you cannot stop the treatment abruptly. And the final diagnosis, we put it as HLH, likely secondary to Epstein-Barr virus infection, or as it's sequelae. So Dr. Bansal, any comment up to this level?
No, this is just fine, sir. Sometimes etoposide is also used for management.
That I am just here because of the actually etoposide. It is more here for the primary HLH. And that's why we have not used in this case, or sometimes patient is not responding, definitely you can use it. But there are different school of thought. So basically dexamethasone or methylprednisolone may be used. Definitely etoposide is another drug. Sometimes cyclosporin may be used. But usually for the primary HLH, it is very important, and where also sometimes some patient may require even the bone marrow transplantation also. So defined terminology, HLH syndrome, HLH disease, macrophage activation syndrome. Okay. So here just one thing I want to mention, the macrophage activation syndrome and HLH syndrome. This is little bit here because macrophage activation syndrome was an earlier term particularly used for the patient with idiopathic arthritis, juvenile idiopathic arthritis and other rheumatologic condition. So macrophage activation syndrome, though commonly we call everything as macrophage activation syndrome, but it is specifically terminology was being used for the rheumatologic disease associated HLH syndrome, specifically called them as macrophage activation syndrome. Etiology, I am not going in details because of the time and here the platform is little different. So any infection or any trigger may actually change your immunological milieu inside the body. There are defined mediators, CD25, IL-2, like that type of molecule. There is transformation of the macrophage in a defined specific type of macrophage, and they have the capability to engulf your own body blood cells or like your platelet, RBC, all these things. And also in during the time of the your COVID-19, you have seen so many reports for the HLH or sometimes cytokine storm syndrome after the COVID-19 infection, not going in the. So about the pathophysiology, this is the bone marrow picture the patient had received, and this is the diagnostic criteria. So there are, you just see in this, there are the initial diagnostic criteria, that is A, point A. So the fever, splenomegaly, cytopenia, hypertriglyceridemia, or hypofibrinogenemia, and hemophagocytosis in the bone marrow or spleen or the lymph node, and after exclusion of malignancy. So out of these clinical features, if you find, okay, there are 5 out of these defined criteria, and particularly the A point defined, you can also suspect, or you might have your suspicion that this patient might have the your HLH. So that's why I will advise all of you to send all these investigations, and then you keep a suspicion as well as probability that your patient might have this HLH syndrome. And also along with this, you also send the ferritin level, that is very important. And what I was discussing about the soluble CD25 and soluble IL-2 receptor. So these are not easily available, but it is important for the primary HLH syndrome where you are considering. And there are different type of these are the different treatment that is available. Okay. So like corticosteroids, cyclosporin A, etoposide, anakinra, and biologicals and other therapies nowadays is also available. Even immunoglobulin may also be used. So without I will proceed with the case number 2. If there is any question till now, you can ask me, then I will discuss. And otherwise, I will proceed with the case number 2.
So I think you carry on. We'll take the questions in the end. So if you have any questions, please put them in the chat box.
Okay. So about the case number 2, this is another interesting case of 30 years old gentleman from Eastern India. Patient was admitted at outside hospital with fever about 104 to 106 degrees, and that too during the month of summer, and with episodes of vomiting, drowsiness, and decreased urine output for 2 days. So this patient, young male patient with very high temperature during the summer season with episodes of vomiting, drowsiness, and decreased urine output. So patient when admitted in the outside hospital in the locally, and patient was initially diagnosed as a case of sepsis. So accordingly, on the line of sepsis, patient was being managed with antibiotics, IV fluids, and other things. On the second day, sorry, not second day, actually patient was being transferred to our hospital after 2 days of treatment, almost after 48 hours of therapy there. So then this patient, we took the medical history and other history also. This patient had also history of diagnosed, sorry for the spelling mistake, diagnosed actually bipolar disorder recently, and patient was started taking clozapine, lithium for last 2 weeks before the admission. And when we examine in our setup, so the patient was unconscious, tachypneic, hypoxic, very high temperature, and generalized rigidity was there, not only the specific neck rigidity. And the patient was also hypotensive. So I will just basically discuss about the possibility. Okay. So if this is the possibility, so what are the possibilities you will consider?
So anybody wants to put it in the chat box? So Dr. Shweta has replied NMS.
Yeah. Dr. Setat, very good here, because of the, if you go through the history, okay, very important that the patient is having very high temperature. As initially in the introduction, I told you that the temperature you just differentiate whether fever or hypothermia. Please, you make that distinction. That will at least give you some idea as well as clinch to your diagnosis with the background history, whatever here. And history taking is very important, that we will later or again we will re-emphasize. So please don't forget to take the proper history from the patient, family, as well as any surrounding evidence. So the possibilities definitely, if we look at the patient's background, the possibility remains like your infection, like meningitis, meningoencephalitis, encephalitis syndrome. So this you should keep as infective, okay, or any sepsis syndrome. But history will give you some idea that this patient might have a neurolep malignant syndrome. And other than that, similar kind of presentation with 104.5 degree temperature, serotonin syndrome may be there. Sometimes withdrawal from the dopamine, it may happen because of the either any dopamine agonist or dopamine antagonist or any withdrawal of the agonist. Malignant hyperthermia, the background is also should be defined. So that will also you should consider, particularly in ICU. You may find that patient after coming from the OT might have some problem. Substance abuse can also give rise to very high temperature, and some of the particularly endocrine disorder, thyrotoxicosis, pheochromocytoma, that can also give rise to this high temperature and high heat stroke, another call it. So these are the usual causes of very high temperature or hypothermia. So this patient was managed on the day 1-2 by giving, because patient was hypotensive as well as the patient was very unconscious. So fluid resuscitation was continued, antibiotics coverage continued with carbapenem, and patient already started receiving the carbapenem and fluoroquinolone. So we continued that antibiotics initially. Vasopressor was added, antipyretics and external cooling applied because of the 105 to 6 degree of temperature that was not responding to actually paracetamol. And not only this, that this patient also received the cold normal saline. Cold means basically that around 20 to 25 degree of year from the freezer, we will give approximately 1 liter of cold saline. And then for persistent anuria and increasing metabolic acidosis, patient was becoming very much acidotic during the course of hospital. Within 24 hours, we had to start or initiate the renal replacement therapy. And also we put the patient on mechanical ventilatory support because of the hypotension and altered sensorium for airway protection. So what investigation you will plan with this background? Already Dr. Seta has mentioned that this patient might have a problem of neurolep malignant syndrome. Please don't forget to send CPK, okay, in this particular type of patient. So lab parameters, we sent all the routine investigation. There was sodium was on a higher side, creatine was 1.77. Patient had almost, that time patient was almost anuric also. So clinically as well as the by criteria, patient had already developed AKI, and liver enzymes elevated, topical markers were negative. CPK was elevated at 8,400, and all the cultures we sent, procalcitonin was negative, thyroid function test within normal limit, lumbar puncture, we did not actually, family did not give any consent for the lumbar puncture because our register told this patient will require lumbar puncture to rule out any your meningitis or meningoencephalitis considering the background. So thanks to the attendant, probably their attendance were right. But if you go by the systemic care, they are not, our register was not totally wrong. And MRI brain was also done with difficulty. After being a patient was given the sedation as well as muscle relaxant, we get that. And that MRI, because we are also considering there may be sometimes hypoperfusion or hypoxemia might have happened when the patient was being transferred, but that was history-wise, there was no such case. NCV EEG could not be performed immediately. So that on the day 3, the febrile without much relief with antipyretics, So considering that your CPK level, we thought that okay, this may be, we thought means we consider a diagnosis of the neural malignant syndrome. So automatically we had given the bromocriptine because dantrolene was not available. And for persistent anuria and increasing metabolic acidosis, the hemodialysis was continued. And also that helped actually in a reduction of temperature also, because after the second dialysis onwards, the patient temperature also controlled. So it is, I don't think it is only because of the bromocriptine or rapid reversal of the NMS that should not happen, but I think hemodialysis helped a lot by in controlling the temperature also, and continued on ventilatory support. Drug history also revealed administration of the metoclopramide for 2 days prior to the previous hospitalization for vomiting. So patient had also given, the patient had actually nausea vomiting 2-3 days before the actually first admission, and he also took the metoclopramide for the vomiting, and that was being prescribed by the local pharmacy. Local pharmacy means the shopkeeper. So now what are we dealing with? So obviously we are dealing with the neural malignant syndrome, and the nearer diagnosis we should, if the drug history was not there, you must consider the heat stroke also, because of the, in our tropical country, particularly summer season, this type of presentation may be more or less similar. Only history can give you or clinch to your diagnosis. So drug history strongly suggests the diagnosis of neural malignant syndrome, and here the probable drug was clozapine, lithium, and injection. Sorry, not injection, tablet metoclopramide. So this is the diagnosis. So anything do you want to discuss, Dr. Bansal?
No, just one or 2 points. How will you differentiate heat stroke from NMS if the patient is taking such drugs like antipsychotics predisposed to NMS? So one is, heat stroke, the LFTs are always deranged. That is one of the features of heat stroke. Secondly, rigidity is a feature of NMS, which is not generally seen in heat stroke. And third is autonomic instability is seen in NMS, which is again not a feature of heat stroke. Heat stroke actually, when it manifests, as multi-organ dysfunction, and the liver enzymes are generally deranged. While NMS, the classic features are, one, there'll be hyperpyrexia, high temperatures, there'll be rigidity, there'll be autonomic dysfunction, and elevation of CPK. So these are the features of NMS, while heat stroke I've just discussed. And the management is different. The thing is, if the patient is receiving drugs with antipsychotics, such as antipsychotics, then NMS has to be considered very strongly.
Should I proceed?
Yes.
Okay. So coming back to the same case, the sensorial metabolic derangement improved gradually, remains of vasopressor. Patient was being tracheostomy performed after failed extubation on day 11 for laryngeal edema. So this patient, once we extubated, because this patient was little obese also. So after taking out the tube within 4 hours, we forced the patient to reintubation, and later we actually directly put the plan for the tracheostomy. So that was what we actually considered in the responded well to winning trial on day 12 and put on the tracheolite, and bromocriptine continued, and on the resolution of symptom dose gradually tapered off.
So if there is laryngeal edema, what therapy would you like to use, Dr. Panja? You want to tell the audience if you get a patient who has failed due to laryngeal edema, and how did the laryngeal edema manifest? So some few words.
Okay. So how can you diagnose? So once a patient is in a critical care unit, you're with tube. So first thing, you have to have some prediction. This patient might develop some laryngeal edema. So there are defined kind of the predictor. Usual predictor, which in case the patient you have during the initial intubation, there was difficulty in intubation. That is one thing. Second thing, manipulation. Too much of manipulation during putting the tube, that can give rise to a female patient usually more susceptible to the laryngeal edema. And also before going for the extubation, if a patient is very obese, okay, and sometimes the obese, very fatty, the flabby, so they may develop laryngeal edema. And before extubation, that is also not a very good, but still a leak test is one test that is available, but it has a positive and negative side also. So just remember here the leak test is one test that can give you some of the guess. And once you take out the tube, so these are the judgment that this patient may develop laryngeal edema, and after taking out tube, so usually patients will definitely develop a kind of stridor, usually inspiratory stridor. And then what you can do, you can initially we nebulize the patient with either salbutamol or adrenaline. Along with that, sometimes we give the steroid. So usual steroid you can give either dexamethasone or methylprednisolone. So that is as therapeutic measures. But as I already discussed earlier, if you have a doubt or guess this patient might strongly develop laryngeal edema, you can also give steroid 24 hours to 48 hours before the actual extubation. So that is for the prevention side. So treatment wise, after giving your nebulization, steroid, if the patient is not responding or patient is sometimes getting hypoxemic, you cannot allow the patient to continue to have stridor. So you have to immediately take a decision. Either you can go for your intubation, or there are other measures. What are the other measures? Sometimes we put the patient on NIV, but NIV is not always good idea, and there is Heliox is there. So helium and oxygen, that is also not available in most of the center. So these are the other therapies you may consider, but because of the non-availability from our center, usually what we prefer, after giving NIV temporarily, if the patient respond to the steroid nebulization, fine, otherwise go for the intubation. And then you should think whether you will go for the tracheostomy or not, depending on the other risk factor. Okay, so this patient had a severe stridor, and not only that, this patient initially the intubation was also difficult. So that's why we thought it will be logical that patients should get tracheostomized.
So regarding the cuff leak test, I would just like to add that you have to have the patient on 450 ml approximately on controlled ventilation, and then you take the average difference between inspiratory and expiratory volumes, and if the leak is more than 110 ml, that means it is all right. That means you don't have laryngeal edema. So it has a negative predictive value, but does not have a positive predictive value, because if the difference between the inspiratory and expiratory volume is less than 110 after cuff deflation, then the difference can be less than 110 ml because of secretions or other things in the airway. So it has a high negative predictive value, and it is not standardized as to what is the optimum management if the cuff leak test is positive. So this was a trial 2 years ago. I think it was published in American Journal of Respiratory Critical Care, where it was known as a comic trial. So evidence is very poor. Like Dr. Panja said, it is not clear how to proceed. If the patient, either if he has a cuff leak test positive, whether he should intubate, whether he should give the steroids and then wait for some time, then extubate, or whether you should do the cuff leak test again after giving steroids, it is not clear. But the cuff leak test has a high negative predictive value, but a poor positive predictive value. That should be known. And like Dr. Panja said, you can give the NIV for some time with steroids, dexamethasone, and epinephrine nebulization, and apply NIV for some time. But then, if the patient not improving, you have to take a call whether to re-intubate or to go for tracheostomy, because these patients generally tend to deteriorate very fast.
Yeah. Okay. So thank you, Dr. Bansal, for a nice discussion on this particular aspect. These are very common, actually, a problem, but definitely we should know, each and every intensivist should know how to tackle the laryngeal edema. So after this, I will just discuss this another case. Okay. So I will just go fast because of the time.
Dr. Panja, in the last case, why did he develop so much hypotension and acidosis?
Actually, this patient, what we are doubting, this patient was very much, actually, till that time, the hypotension was because of the hypovolemia, probably. And not only that, we get the echocardiography. The echocardiography on the day one, once we received that patient, that time the ejection fraction was around 45 to 50%. Probably, I think there was some hypoperfusion related issues was happening. But next day, once we repeat that echocardiography, that was actually normal echocardiography with normal ejection fraction. So our doubt was it was probably multifactorial. One of the factor was hypovolemia as well as hypoperfusion and acidosis. These together actually causing some stunning of the myocardium. That might happen, and that may lead to sometimes hypotension also. So that what was. Not only that, in once the patient is a temperature of 104, 5, 6 degrees temperature, they are very much vasodilated. So there is also redistribution, chance of redistribution hypotension is also there. So that we think that may be the possibility. But if you have anything to add with my thought, so then you can also discuss that issue.
No, I don't know. I think some of the renal failure might have been due to myoglobinuria also, because the CPK becomes high. It is not that high. 8,000 is not that high to cause so much myoglobinuria that will cause renal failure. So renal failure is also unusual for NMS, unless there was, like you said, hypovolemia and hypotension leading to renal failure. That is possible.
Yeah, definitely. Any patient, if there is even sometimes you may see that there are patients with those who are having high hemolysis also. That can also give hypotension sometimes. Okay, so similarly, the what you told that okay, myoglobinuria or sometimes myonecrosis can also give rise to the low blood pressure, like sepsis type of because of the tremendous inflammatory reaction. Maybe.
Yes, sir. Carry on.
Okay. So next two cases that I will give an idea so that in future you never forget that approaches. Okay. So this is another gentleman with 38 years old gentleman with fever, 105, 106 degree temperature for 7 days, decreased urine output, shortness of breath. Just 1 month before this patient was admitted in our ITU. So this patient had a history of depression for about 3 weeks after some family events. And patient was being put on the paroxetine 25 milligram daily for 5 days prior to the actual admission to the outside hospital. And patient also had history of the recent boil infection, and patient was being prescribed linezolid. So patient had more or less 2 to 3 weeks before that there was also boil infection, and patient took linezolid and NSAIDs. Okay, so that was the. So this with this history, can you judge or can you guess anything? Then I will just house, because I am not keeping the details because we want to move on. Okay, so that's why I kept a very small glimpse of the case. And patient was being put on the renal replacement therapy for the acute renal failure when the patient was being transferred to our side. So this patient was also intubated ventilator later for the GTCS. So this case actually we probable diagnosis it was actually serotonergic syndrome because of the two reasons. One, this patient has a history of paroxetine intake as well as patient was being prescribed linezolid. So linezolid also actually inhibits the MAO inhibitor. So if there is linezolid or tramadol or pethidine use, that can cause the works on the your MAO inhibitor or sometimes the other drugs. Okay, that can be with SSRI prescription that may give rise to this kind of scenario. But this patient actually did not survive. But we actually diagnosed this patient was relatively in a shorter time with us, and we diagnosed maybe little late, maybe. So this patient we sent actually CPK.
So basically, he had
CPK was
SSRI plus.
Bansal, I have not kept the details. That CPK was this patient 28,000.
Yeah.
So
So there was an interaction between SSRI and linezolid, leading to toxicity of SSRI.
exactly, absolutely. So actually, I was also being referred on the later part. Okay, later part means on the third day. So that time, patient was very sick, and patient was being treated with multiple antibiotics here. So then I told, okay, you send the CPK, and here. Then I actually discussed with the family what was the history here. So for this type of scenario, history is very important, and not only the short history. You should also take the history of any other drug in the previous year. Not only the present drug, any other drug within 1 month maybe give some idea.
Actually, it's serotonin syndrome, once you stop the drug, is reversible. It does not really
exactly
do modality.
exactly.
But I think because of linezolid, he has gone into interaction, he has gone into GTCS.
Yeah,
and
yeah. And not only that, later on actually this patient
maybe there was overdose also of paroxetine, taking too much or something, toxicity like that.
But this patient had not taken the overdose. Overdose we are taking, it was the actually interesting between the NMS and the serotonergic is that NMS usually the drug history patient may take 2 to 3 weeks of the drug, but serotonergic syndrome may develop within very short time. Even 1 or 2 doses may also give rise to the serotonergic syndrome. Those who are prone. Similar to the malignant hyperthermia, because malignant hyperthermia patient might have history, may not have a, only giving the succinylcholine, okay, may develop or may invite your malignant hyperthermia kind of syndrome. So
yeah, one point to differentiate between serotonin syndrome and NMS is myoclonus is common in serotonin syndrome.
Absolutely.
Myoclonus is not common in this thing NMS. They generally have rigidity.
You are right, and another what you told that very important that once you will stop the drug of the serotonergic, particularly the drug responsible, that patient may respond within 2 to 3 days gradually. And though cyproheptadine one drug may be used, but even without drug use, the most important you stop the drug. And then actually this patient died not only because of this patient by the time developed the AKI, patient later also probably developed sepsis infection also. Though patient was on antibiotics, because the last blood culture, even post-mortem blood culture was positive, I think probably some Klebsiella resistant to the common drug what was being used. So basically that was meropenem or carbapenem producer Klebsiella pneumonia. So that was the case, but initially definitely this diagnosis we may pick up in the early, and if we go properly, then the response and therapeutic result will be much better. And this is very short case. Again, I am presenting this as short because this is another 55 years old gentleman, diabetes, hypertension, dyslipidemia, recently diagnosed as TBD, and CABG was performed 3 weeks before. Readmitted with history of fever and dysuria. Urine parcel was 12 to 15 hyperpil. This patient had also history of the catheterization. So before actually on the second or third day of the postoperative period, catheter was removed. Patient urine parcel was 12 to 15 per hyperpil. Total count was 13,500 and C-reactive protein was 124. Echo, chest X-ray was done. That was normal. So what may be the probable diagnosis? So initially, the diagnosis looks more of urinary infection with a background of recent history of CABG or surgical procedure. But this patient, once we followed that case, the fever continued. Culture sensitivity report was showing Klebsiella pneumonia with 40,000 per high power pill, and it was MDR, multi-drug resistant. Probably patient during the time of hospitalization during CABG received antibiotic. So maybe the reason for the carbapenem sensitive MDR, your Klebsiella pneumonia. Blood culture was negative, but during therapy there was no, in spite of the carbapenem, there was no remission of fever till day 4. So repeat urine culture was done. The parcel was 2 to 4 hyperpil. Later we collect the report also after within 24 to 48 hours there was no growth. Total count remains high, 14,200. C-reactive protein was 122. So do we want to change our diagnostic here, or we want to stick to the urinary infection? That is the question that time. So any thought, anything do you want to?
Audience, any thoughts? Is this UTI or can it be something else? Let us hear from the audience. So there is nothing from the audience. Carry on.
Tunir is there. So Tunir, you can give the diagnosis, no problem, because he was during my that patient. He was with my round. Okay, so this patient I diagnosed after that is post pericardiotomy syndrome. So on the 5th day, I stopped all the antibiotics. I asked that patient, okay, to be on NSAID. If necessary, we may use steroid, but obviously cardiothoracic surgeon will immediately talk against the steroid. So that's why initially I did not. Only the naproxen sodium I had started put on this patient, and I told you can discharge the patient. So within I think 2 days after that, patient became febrile on naproxen sodium. I prescribed that drug for another 3 to 4 days in the house. I told that after 1 year of follow-up. So patient had no fever afterwards, and urine routine and culture during follow-up after 7 days visit, there was no fever. So post pericardiotomy syndrome, particularly if a patient is having any kind of acute myocardial syndrome or acute coronary syndrome or any CABG or any cardiac cardiotomy. So that is relatively usually happens after 2 to 3 weeks of a time. And this patient also remains febrile, and whatever invasive investigation you will do, ultimately most of the investigation result will be negative. And particularly what you need to do, basically you need to rule out any infection, particularly any pulmonary infection, urine infection, or other infection is there or not. If that is not there, in spite of the high CRP and high count, you can consider or the possibility of the post-pericardiotomy syndrome. And the response is very good. In rare patient, you may have to give the colchicine also, particularly in patient with acute coronary syndrome, but not in the first year instance. Initially, you can manage with the NSAID like ibuprofen, naproxen sodium, all these things. And if not responding, sometimes low dose of steroid might respond, or sometimes colchicine may be beneficial. So this is the year. About what we are discussing about the
No, Dr. Panja, just one thing I want to add. What happened to the
Yeah.
Klebsiella? Because that was looking like UTI.
That I think maybe
Because EV count is high, percents are also quite significant, and you're isolating Klebsiella.
I think maybe that was a lower urinary tract infection, maybe a possible. Okay, maybe
Both the things were there. Both the things may have been there.
maybe there, because this patient also complained of dysuria, but that was not the cause of the actually fever. Because if the patient is having dysuria and fever, that should be upper urinary tract infection, where you will get definitely the total count C reactive, that is it. But for the, because this patient also had that year together, because post pericardiotomy syndrome you will get together. But only thing, once a patient was not responding to our antibiotics therapy, whatever we had received, then only we thought of this year. Not that on the first day we considered that diagnosis. So our diagnosis for the post pericardiotomy syndrome depends on the actually first exclusion of the infection. Then only you can think of that possibility. Otherwise, it will be very
Actually,
difficult.
similar thing also sometimes occurs after MI. It is known as Dressler syndrome. It is the same mechanism. Autoimmune injury, autoimmune mechanism. Basically, you are, when you do a cardiac surgery, you are injuring the heart to some extent. Similarly, in MI, there's injury to the myocardium. So antibodies develop to the heart, and you get this fever, which is actually a autoimmune kind of a fever. So in when you get it post MI, it can occur up to 8 weeks. It's become rare now, but it is described. It may be occurring. I've not seen too much of it, but it can occur. And like Dr. Panja has given NSAIDs, the treatment is the same. You have to give NSAIDs for post MI fever also.
Yeah. So it may happen in after the acute coronary syndrome, it is Dressler syndrome, and after your post-surgical it is post-pericardiotism. Basic mechanism more or less same. And about the neuroleptic malignant syndrome, there are different kind of the criteria. So these are the major minor criteria. Okay, so for the time constraint, I am not going into details because I need to go for the approach also. Just you can keep it major criteria, minor criteria. If the patient is hyperthermic, muscle rigidity is there, and elevated CPK. If these three things are there, you can easily diagnose probable neuroleptic malignant syndrome. There are other minor criteria, but we specifically rely on the major criteria. And usually these are the offending drugs. So basically, most of the drugs in the either typical or atypical antipsychotic may give rise to this type of syndrome. And not only that, even a patient with a Parkinsonism or any drugs, which is having dopamine agonistic activity, if you are withdrawing of this dopamine agonistic drug, particularly levodopa, carbidopa, amantadine, so that can also give rise to the your neuroleptic malignant syndrome. So there are a list of drugs. This is just a small list, whatever I have kept the common drugs. And usually management is withdrawal of the offending drug, dantrolene, and not available in our country, but dopamine agonist, particularly bromocriptine or amantadine may be given. Electroconvulsive therapy is one therapy, and most important is basically the supportive therapy. Don't forget, because the best supportive care also give rise to your best result. Without that, and there are also controversial reports nowadays about the dantrolene, bromocriptine, amantadine. That's why I will give more stress on the diagnosis, then withdrawal of the offending drug, and most important is best supportive care. That is the most important. And this is about the heat stroke. So heat stroke, usually already Dr. Topes discussed about the heat stroke. Usually the patient will have hypothermia, CNS impairment, and multi-system tissue injury. It may be classic, exertional, or complications. So most of the patient dies because of the complication, particularly kidney liver failure, DIC, rhabdomyolysis, severe metabolic derangement. So this is about the heat stroke and malignant hyperthermia. Again, it is a genetically determined disease. So there is some receptor gene. So because of this genetic mutation, what used to happen, once you will give this drug, there is calcium uh, from the sarcoplasmic reticulum, this calcium will come into the cytosol or the myocytes. So that myocyte is calcium remains there for a long time, and that give rise to a tetanic or the type of or the muscle contraction that usually happens in the malignant hyperthermia. And the offending drug, usually succinylcholine or halothane, most of the cases diagnosed inside the OT. But rarely it may happen, patient may not respond in the first instance. Your ITU, after sending to the ITU, this patient may develop this syndrome. That may also happen in 20 to 30% cases. So that's why just to remember that after coming from the OT, if any patient develop a temperature of 104, 105, usually it is not because of the tissue injury or infection. Most of the time it may be malignant hyperthermia. That is the message I want to send to all of you. And usually the management is withdrawal of the offending drug, and in OT sometimes you may have to cancel the OT also. And other drugs are dantrolene you may give, and supportive therapy directed to correct the is important. So like hyperthermia, acidosis, and organ dysfunction. And another thing is important if that happens. So you have to have a discussion with the patient family members as well as the surgeon. What will be, how can you proceed for the surgery next time? And not only that, sometimes your diagnosis should be confirmed so that next time if it happens, so that may kill the patient. So that's why it is very important. If there is a slightest doubt, you must rule out this malignant hyperthermia propensity. So that is important. And hyperserotonergic discussion already we have discussed, so I am not going. Then there are drug associated fever. So we are actually drug associated fever is another very common in the critical care patient. So there are so many drugs. So drugs can directly cause hypersensitivity reaction. It can cause local inflammation at the site of administration, particularly amphotericin B, potassium chloride, sulfonamide, cytotoxic chemotherapy. These can cause local inflammation and can cause fever. So it is not related directly to the drug, but because of the local administration and inflammation that is happening. And drugs and their delivery system may contain pyrogen or microbial contaminant. That is another thing. So whatever vehicle they are using, that you may be allergic to that particular vehicle, or any patient may be allergic, that can give rise to the fever. And something stimulation of the heat production, particularly if the patient has taken too much of thyroxine, so that can cause fever. And there are atropine, epinephrine can also cause fever by heat dissipation. Our body's protective mechanism is basically heat dissipation does not take place. So that's why it may cause fever and alter the thermoregulation, particularly phenothiazine, antihistaminic, anti-Parkinsonian drugs may cause alteration of the thermoregulatory center that may give rise to the drug-associated fever. So how can you diagnose? So unexplained high spiking temperature and shaking chill, usually in 2 weeks of the drug administration, may be associated with leukocytosis, eosinophilia, skin rash. So if this combination is there, along with that there is alteration of LFT, so there is one syndrome called DRESS, okay? So that DRESS syndrome may happen, and that time you must have to use the steroid for particular patient and stoppage of the drug. That is very important. And relative bradycardia, although commonly cited, is uncommon. So earlier that was drug fever usually causes relative bradycardia, but that is not true. And rapid resolution of fever usually less than 72 hours. Okay, usually gives a fair diagnosis that drug fever was there, but it may take up to 7 days, even up to 14 days time to actually your temperature may take to subside. And if there is a DRESS syndrome, particularly the subtypes of this drug fever, so that may it may take 2 to 4 weeks time for the remission. The diagnosis of drug-induced fever is usually established by temporal relationship of the drug to of the fever to starting and stopping the drug. So most of the cases we don't do that. That these are the common offender, common drugs, and there are certain uncommon drugs also. So practically the antibiotics and anticonvulsant, they are very notorious for giving rise to the temperature. So that is the common drugs, and also ATD, some isoniazid, rifampicin that can give rise to the drug fever. And there are certain drugs that withdrawal of the drugs can also cause fever. So these under this fever may occur several hours or days after admission to the ICU. Usually patient will have fever, tachycardia, diaphoresis, and hyperreflexia. And in this group of the drugs, particularly if the patient is alcoholic, after withdrawal of the alcohol, patient might have fever. Okay, so that is important. And opiate, barbiturate, benzodiazepine, these three drugs after withdrawal may cause fever. So that is very important message, because sometimes you may forget that patient used to have benzodiazepines at home, but once after hospitalization you have not prescribed, that patient might develop fever because of the drug withdrawal. And sometimes there are fever associated with transfusion, so complicate about 0.5% of the blood transfusion, and it is more common with the platelet transfusion, not with the, because right now it is packed cell RBC, whatever we are using for the giving the RBC transfusion, they are not so common to cause the drug associated fever associated with transfusion, but platelet transfusion is very common to cause fever. Antibodies against the membrane antigen of transfused leukocytes or platelet are usually responsible, usually begin within 30 minutes to 2 hours after blood product transfusion, but fever generally lasts up to 24 hours. And there may be transient leukocytosis for 12 to 24 hours. So that is about defined here. And there are different kind of the temperature management, temperature measurement, because most of the time that is the core temperature and the outside temperature varies. That's why there some a bit of discussion should be there, which one is better. So there are pulmonary artery catheter, urinary bladder catheter thermistor, esophageal probe, rectal probe, oral probe, infrared ear thermometry, or you can also put a thermometer in the your external ear or external auditory canal, and then axillary thermometer, temporal artery thermometer, and chemical dot. So these are the available devices. There is also difference in the temperature between 0.5 to 1 degree Fahrenheit amongst these derivatives. But if you look at the usual our use, so usually it is rectal probe, or sometimes the nasal probe we also use. And but pulmonary artery catheter, urinary bladder catheter thermistor we don't use much. And esophageal probe also it is available but not used so much. So for the common uses, oral or the nasal probe, or your transrectal probe is a good one. But only 1 point rectal probe may show 0.5 degrees centigrade of the higher temperature because of the your in comparison to the other areas. So that is the important. So amongst all this, so pulmonary temperature, this is the actually hierarchy of the temperature probe. Pulmonary artery catheter is the best, intravesical, followed by rectal, followed by oral, and tympanic. So we are in between. In between means neither this side or that side. So the rectal probe usually is good one option. So right now I will discuss before. If there is any question discussion, you can do. Otherwise, I will just discuss about a bit about the diagnostic approach, and then we can just conclude.
I think carry on, Dr. Panja. We will take any questions.
So diagnostic approach already we have discussed. The patient history is very important, as well as the findings that I have not written. I have kept it open for you. And basically, whatever circumstances is there in your ICU environment, you should consider it as a whole. So if there is any device with the patient, if there is one ulcer is there or not. So one side there is history, another side is there is basically meticulous examination of the patient is very important, because you whatever gadget you use, sometimes you may miss one pressure sword on the back, so nothing will change. Whatever investigation modalities you will use, ultimately you will never be able to diagnose the case. So that's why the good history taking and at least on the first day thorough examination of the patient is very important. And there are other things. So basic examination looks at the volume, like in your ICU patient. Usually some patient are on ventilator, some patient is with catheter devices, all these things. So this is a bit a schematic diagram, like basic examination, volume, quantity of the sputum, line, drain site appearance. So if there is central line, how is the local site? If it is inflamed as well as your this site is indurated, probably that may be the site of infection. Surgical site infection is very common, so please look at the surgical site. If not, you talk to the surgeon about the local site. And abdomen, whether there is any tenderness or distension in the abdomen. Along with that, in the advanced examination, there are these gadgets we are using, as well as it is available, as bedside, okay, like stethoscope. So lung ultrasound will give idea about your empyema, consolidation. So that can give rise to your diagnosis, and gallbladder ultrasound for any calculus cholecystitis or your calculus cholecystitis. And so also you may get if there is any hepatic abscess or is there or not. So hidden abscess can be picked up by lung ultrasound, gallbladder ultrasound or abdominal ultrasound. Bladder ultrasound also can give some idea about the condition, whether there is any cystitis or not. Kidney ultrasound help. And there is DVT exam. DVT is basically Doppler examination of the peripheries give rise to if there is any thromboembolic disease, particularly lower vein thrombus or your proximal vein thrombus, that can also give rise to temperature. So this kind of ultrasound probe nowadays is very important for diagnosis of the ICU fever. And just a bit of diagnosis whether to use antipyretics or not. So antipyretics, there is a NSAID like ibuprofen or naproxen, as well as paracetamol is there. So this question very often comes. So there are, if we look at the evidences, antipyretic use, the paracetamol or ibuprofen, there are good, bad, both things. There are good side is basically it controls your temperature, physiological parameters temporarily, but it may not be so because of this study. Initially it was being published, it was showing that the ibuprofen may be beneficial in controlling your physiological parameter, not at the outcome. Very important message. So that's why whether you are treating or whether you are not treating with the fever, it will not change the outcome. And this is one study, particularly the surgical trauma patient. This study was basically whether after giving the antipyretics to control temperature versus not yet, the result is very important for this fact that the temperature should not be controlled in each and every patient, because of giving the paracetamol or antibiotics, controlling the temperature may give rise to higher rate of infection in comparison to not using a paracetamol. And not only that, higher rate of antibiotics use also happened with this group of patients. So use of paracetamol in some certain group of patients might be detrimental or harmful. So because this study was being taken in the trauma patient, post-trauma patient, so it may not be generalized to the medical ICU, but there is a probability that even paracetamol might be detrimental in group of the patient. And so I don't want to go extend further because there are long here. So without that, there are basically few more slides for the post-operative fever. So just I am going to post-operative fever is one of the issues. Bronchoscopy, post-bronchoscopy fever can happen. Drug fever already I have discussed. And non-infectious cause of blood transfusion already I have discussed. Okay. So finally, to conclude, before last one is basically stroke or brain injury. That is central cause of fever. If there is any subarachnoid hemorrhage or intracerebral or intraventricular hemorrhage, that patient might have fever because of the central origin. Okay. So how can you diagnose that here? So you need to just rule out any infection is there or not. If you don't find any infection and patient is have a certain brain structural disease, so probably this patient might have the central cause of fever. So that time you can stop the antibiotics. So with this, I thank you all for patient sharing. And if there is any question or any discussion, then I can answer or I can try to answer. And Dr. Bansal is also there to comment.
So please put your questions. Meanwhile, I would just like to say a few things. Dr. Panja, please stop the share screen. Thank you so much for a lovely lecture. Yeah. So friends, one of the most important things is what is actually fever. Dr. Panja has shown everything, but I'll just recapitulate. So, if the fever, a few readings of 99.5 is not fever. Either there are many readings, persistent readings touching 100, or, if you get 101 spikes, a spike of 1 or 2 spikes of 101, that is considered fever. And how you measure also is very important. Normally, we're using axillary measurement, which can be wrong. So you have to make sure the temperature is correct. And many ICUs use nasal probes, which is generally accurate. And if there's any doubt, then we go for the rectal probe, like Dr. Panja has said. That shows the core temperature, which is 1 degree Fahrenheit more than the actual core temperature. So what you have to be very sure that the patient is febrile. Sometimes it is obvious, but sometimes it is not obvious. A few readings of 99.2, 99.3 is not ICU fever. Then coming to the other point, 50% of the times the rise in TLC is non-infectious in the ICU. and 50% of the times fever that occurs is non-infectious. That is very important. So when you approach a patient who acquires new onset fever in the ICU, you have to look at infectious causes. So that is generally your lines and your VAP and your UTI or your surgical site infection or your C. diff infection. So these are the usual causes which you will be able to make out. But for the others, then you have to start from top to bottom and make sure have a systematic approach. Also review the drug chart, whether the patient has received a blood transfusion or any transfusion, whether any procedure has been done, with any drug fever like Dr. Panja has said occurs after 1 week, and there's no real feature associated with it. Only thing is patient can sometimes look deceptively well despite high fever, and it is associated many times with eosinophilia and a rash, and sometimes even renal injury. So these are some of the things about drug fever. And like I said, you have to have a systemic approach going from top to bottom. You can go from the brain downwards, central fever, and patients who are having an NG tube for a long time get sinusitis, or you can have fibroproliferative phase in ARDS gives rise to fever. That is very important. You end up thinking the patient has VAP. After around the second week in the fibroproliferative phase, even if the ARDS is resolving, patient develops a fever. This is very common, and it is mistaken for VAP. So that should be borne in mind. Fibroproliferative phase fever in ARDS. And acalculous cholecystitis can be very difficult to diagnose. It can be very difficult to diagnose. It does occur, and the patient is generally on the ventilator, sick, and hypotension or multi-system organ is the cause, failure, and you actually need to diagnose it. Then apart from that, do not miss DVT, and very important is phlebitis. Sometimes you put IV lines and nobody checks the IV line site. Nobody checks the IV line site, and there's a gross phlebitis there. So the gross phlebitis has to be taken into consideration, and IV line fever must be borne in mind, not central line, peripheral IV line. That is very common. So these are some of the things I wanted to add. Rest of the things he has very nicely covered. So a couple of questions have come up, Dr. Panja. How to subside central fever and how long it takes to subside completely, and do central fever always require bromocriptine? So how to subside central fever means how to treat it.
Sorry, yeah. Actually, the central fever is like that. What I told you first is diagnosis. The diagnosis is basically you have to rule out other causes of fever is there or not. Usually, this type of fever patient remains very well in appearance. So if you consider a patient with sepsis or infection, the patient usually gets ill. But in a central cause of fever, the patient does not look so bad. And second thing, usually the sweating sometimes may not be that high. Okay, sometimes the fever normally will be basically most of the time the sepsis patient, once you will give antipyretics, the sweating, there will be sweating. But in the central cause of fever, patient might not have much of sweating. And then after exclusion of the infection, if there is central organic cause, means it may be interventricular hemorrhage or sometimes the interparenchymal or subarachnoid, whatever be the hemorrhage, and there is no other obvious cause, no rashes in the body, nothing is there. So then you can consider, then stop the antibiotics or the antibiotics and give antipyretics and cooling measures. That is important because some patient may not respond to your antipyretics sometimes, because whenever there is a set point change in the thermoregulatory hypothalamic center, so that can be okay modified or modulate by giving antibiotics. But in case that is not happening, so then it may be difficult. So that's why antipyretic responder, you may continue with the antibiotics, otherwise cooling measures usually you have to give. Usually next question is how long we should continue or this fever continues. So there is no clear means your demarcation. In my knowledge, usually it may take 1 to 2 weeks time. So usually 1 to 2 weeks means 7 to 14 days time to subside. So that time you have to just keep yourself quiet, and then after that you may expect that this patient might respond. Okay.
So actually, Dr. Shweta, bromocriptine is a drug which is used mainly for NMS. That kind of a fever is different from the central fever we are talking about. So the central fever that is normally talked about is when we have a CNS cause, such as a stroke or a ICH or a SAH, something like that. That is called central fever. Bromocriptine is used in NMS. So these are hyperpyrexic state. These are hyperpyrexical states. So this is different. Here the set point goes up because of the set point remains same, but there's a failure in the the heat losing mechanism. That is the main mechanism. And like Dr. Panja said, for central fever, you give either PCM or you can even give diclofenac. Sometimes they respond. If they don't respond, you have to give cooling. But they are generally, central fever is not high fever. Central fever associated with strokes, tumors, ICH is not high fever, and it subsides, like Dr. Panja said, in 1 or 2 weeks. So it is not really a matter of concern. But the thing is not to miss it, because if the patient has fever, which is central fever, and you start treating it as something else, then there's a problem. If you start, giving antibiotics, antifungals, that will lead to bad outcomes. That is the thing. You have to recognize it. So any other questions?
So I think there is no question, Dr. Bansal.
Okay.
So
I think we'll stop it then, Dr. Panja. Thank you so much.
thank you, Dr. Bansal, and also the audience for being with me and take the pain of listening.
Yeah.
I think I have tried from my side, and it is one of the very important topic. And not only that, the take-home message, I can say that the diagnosing infectious versus non-infectious is very important. And second thing, clinching to a diagnosis, because at the end of the day, if you can diagnose early, the outcome is always best, or better, or sometimes best. So that's why it is very important. And please be with the patient. Give some time. I think in most of the cases, you may get actually answer what is the cause.
Thank you. Thank you, everybody. Thank you, Dr. Panja, sir.
Thank you. Okay.